Good afternoon, everyone. My name is Gara Lloyd Lester. I'm the Director of Community and Coalition Initiatives at the Suicide Prevention Center of New York State. We welcome you to the third in a series of workshops being coordinated by a steering committee of public safety officials, veterans, military service members, looking to come up with recommendations and strategies to address suicide prevention amongst these individuals. This is, again, the third in a series. They are not sequential in nature. There are a variety of different topics. And as you see on the slide deck this afternoon, today's topic is going to be suicide assessment, first responder communities, what we know and what works. We have 90 minutes budgeted for the conversation today, so there will be time for Q&A. You can use the Q&A function throughout to pose any questions, and Dr. Anderson has also built in some time at the end of the workshop. And we're very delighted to have Dr. Anderson with us today. Drew Anderson is an EMT and associate professor of psychology at the University at Albany, SUNY. He is an active teacher and researcher at the University at Albany and also maintains a part-time private practice in the Albany area with a focus on cognitive behavioral interventions. He's been an EMT since 2011 with Del Mar Bethlehem EMS, where he's currently a lieutenant and the director of behavioral health. He's also a firefighter and a lieutenant with the Del Mar Fire Department. And we're so very fortunate and grateful for Dr. Anderson's time today. With that, I'm going to turn things over to Dr. Anderson. Drew, thank you very much.
Great, thank you. And thanks for having me here today. We do have 90 minutes, so we have a little time to stretch out. And I did build in, as Gara said, some time at the end for some questions and some commentary. I'd like for this to generate some discussion and some thought. I know we've got a variety of people, a pretty big crowd from different backgrounds. So I think that we want to sort of find some common ground. As you said in my introduction, I'm a psychologist. That's kind of my day job. I'm a psychologist. I have a private practice, and I'm a psychology professor. But I've also got a fair bit of time in for both the EMS and fire worlds as well. And so what I like to do is bring in some of the knowledge that I have from the mental health side of things and bring that into the emergency services world. Not that you need to be a mental health professional to do any of the stuff I'm going to talk about today. Really what I've done is kind of adapted and adopted some things out of my sort of psychology world that we can all use that without any really more than kind of minimal training. So to start this off, I want to kind of give us a little bit of context because we're going to be talking about suicide and suicidality. So I want to give you a broad overview of suicide kind of in the United States. And so see if I can get this to work. There we go. So let's start with some of our numbers about suicide, broadly speaking, across the U.S. So what do we know about suicide in the United States? We know that right now, it's the second leading cause of death in individuals aged 10 to 34, second only to accidents. If you look at that, that's really covering from early adolescence all the way to kind of when I was younger, I used to think of as middle age, and now I think of it as early adulthood. And then as we go a little bit further into what I now think it was middle age, it becomes the fourth leading cause of death. Now, this is unfortunately not because rates of suicide go down. If anything, our rates of suicide in middle-aged males are actually really some of our high rates. It's just that other things, other chronic diseases kind of catch up. Cancer, heart disease, diabetes, some of those other top causes of death start to become more of a factor. So this is a little deceptive in looking at it. It's actually that if anything, we're getting worse. So if you take those first two numbers, we're really talking about kids really much younger than 10 don't have a conceptualization of death the way adults do. So basically, from about as young as children start to understand what death and that death is permanent, all the way up to the middle age, it really is our top in our top 5 causes of death, which is pretty significant. And overall, if you start including, the entire lifespan, including infancy, where it's really not a significant factor, in some of our elderly, it's still a 10th leading cause of death overall in the United States. That number has been pretty stable over the last couple of decades. So we do know that suicide is significant. And as we'll see, if anything, some of the more recent numbers are looking less good because it's getting worse, right? We have done in the medical community, we've done amazing things at cancer treatments, at heart disease treatments. You know, people are living through multiple heart attacks that would have killed them 20 years ago. We're doing really good about our top 10 causes of death, except for suicide. And if anything, as we'll see, rates of suicide in the United States are increasing pretty dramatically. So again, across this is not among first responders, this is in the entire community. We know that from 1999 to 2016, those are the most recent kind of big numbers we've got out there. Overall, in the United States, suicide rate increased to 28%. For those of you who are numbers people, those are some of our numbers, which is, again, you know, that's relatively speaking, that's pretty disturbing. And then since most of us on the call, I believe, are in New York, I grabbed the New York numbers. We are right on par with the national numbers. So New York saw, same database, saw a 29% increase in suicide from 1999 to 2016. So again, when we start talking about suicide among first responders, I think it's important to remember this, is that we have an epidemic of suicide in the entire culture. Right? This is not limited to first responders. We could spend a lot of time, and I know that on other calls and other contexts, we have spent a lot of time trying to figure out and maybe think about what might be causing that huge jump in suicide rate in the United States, broadly speaking. But I do think, you know, it's important to think and not think that we're alone in this, not think that first responders this is somehow a problem of our houses and nobody else. You know, this is a problem we have to deal with in America more broadly. So even as we fix the problem within first responders, we have to think more broadly about the problems we're seeing, again, in our entire culture. So I always like to lead with that, so we kind of frame our discussion of first responders appropriately. And so then if we want to look at, I'm going to go through just a few of our kind of specific subgroups in here and talk a little bit about this, because what we do see is that first responders across the board are at higher rates or have higher rates of suicide and are at higher risk than even the general population, which is already seeing, again, this sort of epidemic. And so this is a study that came out a few years ago, and they found that rates of thinking about suicide, so suicidal ideation, and suicide attempts are roughly 10 times higher than the general population. So those numbers are scary, both from a relative point of view, so we're 10 times higher than the already increasing numbers, but also if you think about, you know, in this particular survey, you know, 2 out of every 5 EMS providers at some point in their career thought about suicide, and we had about 7% who actually made a suicide attempt. Those numbers are scary in both absolutely and relatively. So that was a recent EMS one. Let's look at fire. This is from a different database or a different survey, different review. Again, we see some pretty disturbing numbers. So these were, I believe, all career firefighters in this particular survey. Again, suicidal ideation running 40, almost 50% at some point in their career had thoughts about suicide, with almost 20% making an actual plan. And as we'll see, a plan is a pretty far down the line when it comes to suicide, with almost 16% having a suicide attempt. These numbers actually were worse. There's some other studies that shown that firefighters that also do EMS have higher rates than firefighters who just work fire. That makes sense. You know, maybe you've got twice the exposure to traumatic events, for instance. And then I just wanted to point out police, law enforcement. I know we've got some folks from law enforcement on here. This was a study that found that the rates in police are 4 times the rate of firefighters, right, which is already horrible compared to the general population. This is not to compare, like, you know, EMS is not as bad as fire, not as bad as police. All those numbers jump around depending on the studies that you see. The point here is that no matter what your first responder service, I'm not even going to discuss, you know, rates of suicide in the military and in our veterans, because we know those things are incredibly elevated as well. But the commonality here is we're seeing something about those first responder communities. And in other talks and other times, I think we can really go into detail about what that might be. But we have significantly higher rates of suicide and suicidal ideation, suicidality in general, amongst our first responder communities. And it's difficult to sort of look at these numbers because each sort of first responder community kind of keeps its own numbers. You know, the VA keeps its own numbers, DOD keeps its numbers, fire service has its own numbers, but what we're starting to see as we come together and try to come up with some common ground here, we're seeing that in recent years, that in all of these professions, or all of these first responder communities, rates of suicide are high, or suicide deaths are higher, have been higher over the last few years than line of duty deaths across all of them. So basically, these days, if you are a first responder, you are much more likely to die by your own hand than you are in a line of duty death. Right? Doesn't matter if EMS, fire, police, any of that. This should be a huge wake-up call for us. That we spend a lot of time. Again, I'm in the fire service. We spend a lot of time talking about maydays and saving ourselves, and fast teams, RIT teams, but we spend very little time, relatively speaking, thinking about suicide, even though that's what's going to be much more likely to kill us, right? So that's why I think I'm really glad for this opportunity today, because we're really starting to notice that we have a real crisis, even in our larger culture, but within our communities.
Drew,
Yep.
a question had come up, I'm sorry, in regards to one of the previous slides in terms of the number of firefighters and police officers polled.
Yes. I can't pull up the exact references because I've got my slides. I've got my notes in my slide notes. Whoever has that, I would be happy to send you actually the original articles. If that one of them, I know the ones for fire was a review article by a guy, Thomas Joyner, who's a big suicide expert in the United States. And I cannot remember the one on police came from, but I've got the original reference for you if you want it.
Excellent, thank you.
Yeah, and by the way, if anybody wants any of the original references for any of this stuff, feel free. I'll have my email at the end. I'm happy to send you all of my original sources. I have PDFs of all of them. I'll send them to you. All right. So the problem with this is, we've got these line of duty deaths. Here's the thing we all have to come to terms with. This is not going to go away anytime soon. And I'm not just talking about the larger suicidality in the United States. I'm talking about first responder suicides, partly because some of the issues around first responder suicides, things like the stress, financial stress, low pay, fatigue and shift work, being away from our families and feeling alone on holidays because we're working, right? Those things are not going to go away anytime soon. I do give a lot of talks on like sleep and suicide and sleep and resilience. And I think that we're starting to see some changes in some first responder communities about that. But talk about if financial strains are a part of what causes people to become suicidal, we're not going to fix the economy quickly. So even the things that I think are sort of fixable, they're not going to go away in a year, 5 years, 10 years. And some of this, frankly, is never going to go away, right? Emergency services are, 24/7, 365, right? There's always going to be some fatigue associated with this. And again, this is not the time for me to go in. I could spend some time going into kind of theories of suicide. But one of the theories of suicide suggests that one of the main risk factors for suicide is developing the capability or the capacity to end your own life. That most people actually couldn't bring themselves to do it. And that one of the biggest risk factors is having a lifetime experience of pain, suffering, illness, and death. And right, who sees a lot of pain, suffering, illness, and death? All of our emergency services, right? So this is why we see high rates of suicide in veterans. We see it in police, in fire, in EMS, in our emergency services, because that is built in to the nature of emergency services. That is never going to go away. And we think that confers a lifetime risk for elevated suicide. So for everybody on this call who was involved in emergency services, I know they probably didn't tell you this because they didn't tell me this in my EMT class, and they didn't tell me this in Firefighter 1, that by being involved in emergency services, you will, over time, if you stay in those services for long enough, you will develop an elevated risk for suicide just by the nature of what you see and what you do as part of your experiences in the first responder communities, right? That is never going to go away. I think we need to own up to that. We need to acknowledge it, and we need to start planning for it, right? We can't pretend it's not there. And I think that we've kind of put our fingers in our ears and said la 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 about this, or assumed that we could make some structural change and that those risk factors are going to go away. We can minimize it, and I think we should. We should do everything we can do to minimize it, but we should acknowledge that we're going to have people in crisis in emergency services. It's the nature of the beast. People are going to see things, people are going to have stressors and strains within that service, or again, just in general life, divorces, problem with kids, financial issues, whatever it may be. And we need to plan for that. And that's what I really want to talk about today, is not some of these, is acknowledging the fact that we got to do something about this because it is a built-in feature of what we do, right? And so if we don't start to intervene, right, if we don't do anything about this, this crisis is just going to continue. The numbers are not going to change. It might even get worse. But hopefully you're on this call, this webinar, or whatever, because you find this unacceptable, right? And so we've really got to start doing something about this. I talk about this a lot, and we talk about it a lot. What I'm a little worried about is we don't usually go beyond talk and start to develop programs. So if we don't start, it's gonna just keep going, right? But on the other hand, if we can start to build in assessment and intervention tools and strategies, sort of things coming from the mental health world, like I'm going to talk about today, and other places, right? If we can start to build those in and make them a feature of emergency services culture and emergency services, we can actually get people who are in crisis the help they need, right? This is what's going to reduce suicide rates, is actually getting in there and doing active things to help people, to identify and help people in crisis get the help they need. That's the entire kind of point of what I'm here to talk about today. All right, so I like to do outlines, kind of let you know where I am. So feel free, if any of this is boring, you can fall asleep and wake up when we're in the exciting part for you. But I am going to talk a little bit about an overview of the process, how we kind of think about a pretty simple framework for thinking about helping someone in crisis. That's what I'm going to do first. And then I'm going to use that framework to talk about how you can conduct a brief, effective suicide assessment. And again, this is not something you need to be a mental health professional to do. This is something you can do with pretty minimal training. It's just a matter of knowing how to frame and ask the right questions. So this is the assessment piece, what you can do to find out if a person is in crisis. And if they are in crisis, how significantly you should be worried about them, right? And then also discuss some immediate interventions for safety, right? Again, most of the people on this call are not mental health professionals. I'm not asking you to become one, but there are some things that you can do, that agencies can do, and you as an individual can do to start to work on building safety for individuals who are in crisis in your various respective services. All right, so let's talk about an overview of the process. And there's a lot of different frameworks I could use here, and I picked one because I'm familiar with it, and I think it's an easy one to help understand. But the first point I want to make is that you've got to know someone's in crisis before you can intervene. This is, in some ways, the sort of the crux of what I want to talk about, is that if you don't know, you can't do anything about it. And the problem is, this is a very active process. You have to ask questions. You have to inquire. You have to be paying attention. The problem is that we are horrible at this in emergency services. Right? What's interesting to me is that we are very active people by nature. Right? We come in, we take control of scenes, we ask questions. Frankly, we ask embarrassing questions of patients, or again, whatever. We see people at their worst. We're really good about doing this with strangers. We are horrible about doing this with each other. And why is this? Lots of people have lots of different potential answers. Some people might say it's the EMS and fire and police cultures, right? That we are, we don't like to admit that we're in distress. We like to be the sort of the bulletproof and vulnerable people. And so admitting that we are hurting is hard. Asking questions and asking someone else that you know well to admit that they're not doing well, that can be difficult. So there are some cultural issues, and I think, as we'll see, we're going to have to chip away at that. It might also just be simple embarrassment. That again, you might be very comfortable asking this of a stranger, but somebody you've known for years, somebody frankly, the bonds that we build in emergency services with our coworkers and our friends, can be pretty deep, and to sort of open up like that or to ask a question of somebody might be difficult. And then we also see some things about the bystander effect, which is, let's say I notice, hey, Ed is not doing really well. It seems like he's not himself anymore. And I talk about that with a couple of our my colleagues, either in EMS or fire. And we say, yeah, they don't look like they're doing well. No one wants to be the one to step up. Like, those other guys will say something to him. I don't have to say something because it's awkward for me. I don't like it, and so this sort of idea of what we call diffusion and responsibility. Someone else will do it, right? And so if there's anything that I want to do today, it's to empower everyone and to encourage everyone to start thinking about themselves as the person who needs to step up and be active at this, right? Because there's lots of barriers to this in our culture, in our individuality, and again, some of these other psychological characteristics that make us not naturally good at this, right? So like I said, I do a lot of this kind of training, and this is the hardest thing to get people to do, is to be able to, again, I'll go back to, this is an active process. We've got to do things, right? Magically, as we'll see, people don't come to us and tell us they're in crisis normally. We have to figure it out, or we have to ask them, right? And again, we're bad at this, right? But luckily, there are some really effective, learnable frameworks that teach us how to ask and intervene. And again, I'm not talking about a mental health professional, standpoint. This is just from you as a layperson, as a trained first responder, but as somebody who may not have a big mental health background can do. I'm going to give you one of these. It's a version of gatekeeper training called QPR. Some of you may be familiar with it. I happen to be a QPR trainer. That's not why I'm doing this necessarily. I just do think it's a nice framework. I get no money from QPR to sell them, because I'm not really selling them. But like I said, I think it helps us think about the steps we need to take to be effective interveners for our colleagues who are in crisis. Right? It's called gatekeeper training because the metaphor is kind of you become the gatekeeper between a person and getting mental health services. So you kind of open the gate and usher them through, if you will. And so again, if you're not familiar with it, QPR stands for question, persuade, refer. And here's a little bit of the process. So the first thing you have to do is you have to ask a question. You have to say, hey, are you doing okay? You seem off. Are you all right? I'm a little bit worried about you. Some version of that, right? That's an active process. So once you question, and if that person says, yes, I'm actually in crisis, I'm not doing well, I'm really struggling with that, the outcome of that call, or I'm having some problems at home with my family, that you can then go on to persuade that person to get help, and then you refer them to get help. So if you see here, that's why they call it a gatekeeper training, right? Because you're not doing the intervention yourself. You're just identifying a person in crisis and pointing them in the direction, and it's actually assisting them to get the help that they need, a higher level of care, if you will, right? So that's QPR. And I'll tell you why I want to pull some pieces of it that I think are really helpful about it. And again, there are other gatekeeper trainings out there that will also work very, very well. They look pretty similar to QPR. So that's why I wanted to point it out. The important thing here is that this is an intervention at the provider level, at the individual level. This is not something that is brought in on high. This is not something that your chief or your medical director does every few months. This is something that you train everybody in your agency, your organization to do, because you're not going to talk to the chief, the lieutenants about this, right? Who are you going to talk to if you're in crisis? Who's going to notice you're in crisis, right? That's your colleagues, your coworkers, your partner. That's who's going to know. The people who know you the best, the people who see you the best, have seen you at your best, have seen you at your worst, right? So the idea is that intervention has to happen at the level where people are going to notice this. It's likely that's most likely going to be at that individual kind of street level provider, frankly, right? And the theory is this, and this is what I think it's important for you guys to understand and kind of take home. Again, I'm stealing this from QPR, but it's not unique to them, is that most individuals who are suicidal do communicate their suicidality before an attempt. In some way or another, they let it be known that they're in crisis. The problem is that we're often looking for this overt, hey, I'm really struggling, right? And the problem is that the overwhelming majority of the time, people are not going to give you that overt signal. They're not going to kind of walk up to you in the firehouse or, wherever you are, if you're on a call and say, hey, by the way, just so you know, I'm actively suicidal, right? What they will do is give you some covert or coded messages that they are not doing well. So this could be something like, it's been good working with you, and there's no reason, that they're not retiring. So it could be a verbal message. It could just be nonverbal communication. It could just be, one of the things we talk about is someone starting to withdraw and not, hey, you used to sit around and joke with us, sitting around the EMS room, and you don't do that anymore. What's going on? But the idea is that again, people will rarely do this overtly, but if we're paying attention, we know what to look for, we can actually start to notice some of those more subtle cues, and then we act on them, right? So the training and is these kind of gatekeeper trainings is to detect it. Hey, I've noticed you don't seem like yourself, and then respond to them, right? Because the idea again is at that street level, you may be the person. There may be only a couple people who really know that person well enough to know that that person either might feel comfortable enough to kind of throw it out there a little bit, like, I'm going to say something, maybe see if they pick up on it. Or they may notice the fact that I'm kind of pulling back and withdrawing. I'm not joking the way I used to. So there may be only one or a couple chances to intervene. And so that's why we need everybody to learn how to be able to do this stuff, so that everybody can feel comfortable, and everybody the more eyes that we have out there paying attention to this stuff, the more likely we are to be able to catch people. All right, so that's the framework that I like. That's why I like it. There's a bonus here that I think is really important to notice, and that's that these kinds of trainings, even the stuff I'm doing today, starts to change the culture. As I said, we really need to change our culture around feeling comfortable asking people about distress and crisis, and people talking about their own distress and crisis. And we are across emergency services and across first responder communities. Again, we're horrible at this, right? We are the invulnerable ones who don't like to admit that that call really affected us, or that that I'm going through a problem, a breakup at home, or some financial issues, or whatever, right? So one of the biggest things we're going to need to do is everything we can to start changing that culture, and this is one of those things that does that. So as I said, QPR is a great framework, but I'm going to go beyond that today. This is not a QPR training. Again, I'm not getting any money from the QPR people. What I'm going to talk about is I'm going to break it up, and where QPR talks about questions. So opening that up, I'm going to go into a little more depth and teach you a little bit more about a good assessment. So it's beyond a simple question. And then what QPR refers to as the persuade and the refer, I'm going to kind of glom into this notion of intervention. So what can we do as agencies? What can we do as individuals to start to intervene while we're getting that person to the higher level of care? Because as we'll see, that doesn't always or even frequently happen immediately. Right? There's a little bit of a gap. And that's a place where we can move some intervention. So I'm going to take this QPR framework, like I said, and go into depth on both of these and go beyond a lot of what you might get in one of these normal gatekeeper trainings. Because I think, again, this is stuff that I want to discuss at the end of this presentation, but also for everybody on this call to kind of go back and think, again, how this might fit into their organizations. All right, so let's talk about suicide assessment. And how do we do that? It's important to know, to start off framing suicide assessment, that suicide tends to follow a fairly standard progression. And what I mean by that is people who become suicidal, who have a completed suicide, have typically walked through a series of steps. And I think it's important for you to know these steps, because as we will see, the more that you know about the progress and natural progress of suicidality, the more you're going to be able to think about levels of risk, relative risk. Is this person at a relatively low risk, or is this somebody where I've really got to not let them out of my sight until we can get some intervention in there? And I think if you understand this process, that helps you be a lot better at this, which is why I like to teach this. So let's talk about suicidality and what this progression looks like. And this is it all in one slide. I'll go into details in just a second. So it starts on the left with suicidal ideation. That's really, as we'll see, any thoughts about dying, one's own death, suicide, typically pretty passive, can start to get a little more active. And then some people, right, not everybody who has suicidal ideation, will move on to have more serious levels of ideation. And there's kind of some fuzzy lines here. But at some point, they start to move to a little more active kinds of thoughts. Not from I really wish I were dead to I would like to end my own life. So they start to build some intent. Some people who develop intent will go on to make a plan. Again, these numbers get smaller as we go through. But a plan is not, would I do it, but how am I going to do it? And as we'll see, there's some important things to know. And then really the step after the plan is a certain subset of people who develop a plan will go on to have a suicide attempt. Some of those attempts will be successful and will have a suicide death. This process can happen very slowly over the course of months. Let's say if a person's having some financial issues or something like that, it can happen very quickly. We'll see this can happen over the course of a couple of days, a day, or sometimes even rarely over the course of a few hours. But in any event, whether it happens slowly or whether it happens quickly, it follows the same progression. We tend to see the same steps happen. I'm going to try to do something. You guys can see that? All right. So let's go through step by step. Let's talk about suicidal ideation. Right? So this is the first step in the suicide process. This is any thought of suicide or death. Again, this can run from everything from I just wish I wouldn't wake up someday, to I wish I got a disease and died, to thinking again about starting to think about ending one's own life. And it's important to talk about suicidal ideation, because the first thing you need to know is that suicidal ideation is actually relatively common. Some people have argued that most individuals at some point in their lives, typically under some sort of crisis, will have thoughts of death, dying, or ending their own life. Typically, again, pretty passive, but this is actually pretty normative, right? That if a person is in extreme pain, physical or emotional, that one of the things we'll turn to is thoughts of, I just want to make this pain go away, right? And so that's suicidal ideation. What causes it? Well, some of it is what many of you might expect. A diagnosable mental illness. A person could have an anxiety disorder. They could be depressed. They could have bipolar disorder, PTSD. People have argued that the majority of people, or at least a pretty substantial percentage of people who do have a suicide attempt, at the time of the attempt, do have a diagnosable mental illness. So it's important to know that some of this comes from longer-term mental health issues that are maybe exacerbated by something. But at the same time, chronic pain, chronic illness, right? Just, people who say to themselves, I don't want to live 20 more years with this level of pain, right? We do know, I'm going to go back a second, that rates of anxiety, depression, PTSD in particular, amongst first responders are much higher than the general community. So we do have elevated rates of mental health issues in first responder communities. But any of those of us who've been involved in emergency services for a while and doing first responder work, you get banged up, right? So getting chronic low back pain from lifting that patient the wrong way, as I got myself. Chronic illness, just as we get older, this idea that I see myself on a downward slide and I don't want to go out that way is the kind of language we'll hear people say. So this is also a risk factor for developing some suicidal ideation. But even more broadly, anything that triggers shame, despair, or humiliation, feeling like one is a failure can trigger this, particularly really high levels of this. And so in emergency services, we can see this most often in a person who feels like they fell down on the job. They didn't save that patient. Somebody died because of me. That fire got out of hand because of me. Getting harshly criticized and feeling like, and internalizing that, feeling like, yeah, I really do suck at my job, and I'm not going to get any better at it. That kind of I am broken idea can trigger this. We see this in the more general population. Somebody who gets arrested for something really embarrassing, it comes out in the community, and they feel that sense of intense psychological distress. And we do know that emotional pain and physical pain are actually felt similarly in the body, kind of processed similarly in the brain. And so that high levels of physical and emotional pain can both lead to this desire to want to make that pain go away. And one of the things people will turn to is thoughts about ending their own life, right? So that's kind of the downside of this, if you will. But luckily, most suicidality, not much, but most suicidality stays at the level of ideation. As I said, many people who think about it passively, even somewhat actively, could never bring themselves to do it. And one of the things I want to bring up in this context is the notion of protective factors. So what is stopping that person from going further down that process, right? Because again, once we know where this person is and if they have protective factors, it helps us gauge our risk a little bit better. Right, so these are just some of the most common ones. There are a lot of them out there, but the things we hear time and time again are sometimes people have moral and religious opposition to suicide. I feel like I'll go to hell, or it's a sin. Now, saying that, I do know that a lot of people who do have completed suicides are religious, right? So it's not an absolute barrier to suicide, but it can be something that makes people slow down their progression a little bit or a lot. And for some people, it really is an absolute barrier. I just can't, as much as I wanted to, can't do it. I've had patients who've said that. As much as I really want to do it, I can't do it because I'll go to hell, and I don't want that. We also have obligations. So, who would take care of my pets? Feeling like that you're a valued part of your job. Nobody could do this without me. We do know that feeling like you are a valued part of something is a big preventive buffer for suicide. So that's something we see as a protective factor. Also, the effect on others. I wouldn't want to put my family through this. I know this would tear apart my kids, my parents, my spouse. And we also know that feeling like that one is valued is a buffer against suicide. So people will tell you, like, I could never do this because I've seen, unfortunately, many of us have experience with people we know having had a completed suicide, and we know what that's done to their family members, and we say, like, I could never do that to my own family, to my own friends, and so that becomes a protective factor. So that's important to know, because that can stop us in our tracks, if you will, going down further down that suicide progression. And this is typically where it stops people, is that they don't go any further because I'll never do it because X. All right, but for some people, they move on. And again, I say that we move on to intent. Intent is really starting to move from thoughts, more passive thoughts, to plans. So we start thinking about going from more passive to more active thinking about suicide and death. Right, so then we get to plan, and I will say that once we get to the level of plan, again, most suicide stops before this. Suicidality stops before this. If someone gets to the point where they've had a plan, this is really kind of a red flag. We've got to do something about this. But what are we looking for? So in the plan, we're actually looking at how they're planning to do it, right? What is their plan? Because we have to factor a couple things in when we're evaluating risk, right? We've got to evaluate their means and their lethality. So means are just, what are they planning to do, and do they have access to that? So if a person is planning on dying by firearm, do they have access to a firearm, right? This is why we see such high rates of death by firearm amongst military and police. Not only do they have access to firearms, they're trained in their use, right? We see lower levels of firearm death amongst police and non-military. Now, people may have access to firearms and be in the fire service or EMS or whatever, but the point is that, does this person have access to pills? Do they have access to the way it is that they plan to do this? The easier the access, the more risk. Also lethality. So the kind of the stereotype or the prototypical most lethal means that most of us think about is a firearm. Again, why? Because if a person takes some pills, depending on the dosage, depending on the pill, depending on the time to care, we can actually stop that process, right? We can get that person into treatment and reverse the poisoning and the overdose. There's no coming back from a shotgun blast from a firearm. So we really worry. The more lethal the means, the more we worry, right? And there are some other lethal means out there that are available for people. Unfortunately, on the internet, you can find plans on very lethal means, but they involve chemicals and things like that. And so if a person has access to those, we want to try to take them away. There's a couple more additional factors I want to talk about when we're kind of thinking about suicide. Again, one is that history of attempts. Right? Has the person made a suicide attempt in the past? The reason this is important is because if a person's ever gone that far, so that person has at some point in their life gone all the way down that suicidal progression. They were unsuccessful. It was not an unsuccessful suicide, but they did go that far. So if they've gotten that far once before, the thinking is that they may, if circumstances align similarly, they might have another attempt because they've proven that they could do it in the past. So that's something we'll look at, and also alcohol use. A little bit controversial in the suicide world. Some people say it's a big factor, some people don't. But the theory is that when a person is drunk and they're intoxicated, they become more impulsive. They might go further down that list. If they kind of have a vague plan, they might jump on it when they're feeling impulsive and really upset when they're intoxicated. So those are things to look at. So those are some of the risk factors. So I'm going to go back to start talking about doing a suicide assessment. These are really the key things we want to look at, right? And so many of you, as I'm going through this list, I've spent the last X number of minutes, I don't know how long, kind of going this over, is you're like, wow, this is pretty complicated. Some of you might be taking notes on this stuff and thinking, how do I do this? I am not a mental health professional. Like, how do I go about doing this? So I will get questions often, especially if we're live and people can raise their hands, like, this seems pretty hard to do. Isn't this complicated? My answer to you is no, it's actually not complicated. And what I want to walk you through now is kind of distill all that down into a pretty brief but thorough suicide assessment, how to talk to somebody else about suicidality so that you can get whether or not they're at risk, and if they are at risk, how risky, or how much at risk.
Drew,
Yeah.
if I can interrupt for just a second, there's a bunch of questions that I'm tracking and we'll put towards the end, but one came up that I thought was sort of relevant to just the last portion of what you did, and it was around the idea of what about fleeting thoughts of sort of in air quotes, I could do it such and such a way or another way, but no, and they don't settle on a plan and completely deny intent or means or even actively wanting to die. Right. The person said that they've run into this many times with patients recently. Any thoughts on that particular element?
Yeah. That's a really good question. I mean, I think that even though at some level that person says something like a plan, I really think of that as more of that kind of the ideation level. And if they're, and again, you have to know the people. And then I think the good thing about this is you're normally in this context going to be talking to somebody that you know at least reasonably well, if not very well. If they go, no, I just was one of those things, it was this kind of weird thing, I was really in the middle of a crisis. No, I would be a little bit more worried about that person, right? Because if they kind of jump to that and then something pulled them back, whether that be a protective factor or just the crisis ended, I would still kind of, raise a little bit of a yellow flag that we want to talk about this a little bit more, but I wouldn't immediately, just because they said, I thought about, driving my car off the road or something like that, or jumping off a bridge, that necessarily means they're at the planned stage. Some of us, unfortunately, because of what we do, someone's a police officer, they've got a firearm, they got a department issued sidearm, they're going to go, well, that might be their natural way to think about it because it's just right there and they're around it a lot. So I wouldn't necessarily jump straight to plan. I would really try to get, as we'll see, there's no one indicator, but that might make me think a little bit less worried about them, particularly if they're like, it was just a second or it was just something happened. I was really upset one minute. I thought about it, but I'm back to where I was. As we'll see, I'd really emphasize the protective factors on that one too. Hopefully that answers the question. If not, we'll get you at the end and I can ask more of that. So, so here's what we have to do. I've said this a couple of times. I'm going to say it again. You have to ask the questions. People are not going to volunteer suicidality to you. They're often, in a lot of first responders, they're not even offered distress to you. The most you're going to hear is, man, that was a rough call, or that was a roof, that was rough, or I'm really wiped out. I've done a couple 24s this week, and I'm really exhausted. That's the kind of language you're going to get. You're not going to get someone going like, I'm actively suicidal, right? Again, it's not that it's never happened, it just rarely happens. I want you to think you're going to have to ask. You're going to have to step forward and be responsible for pushing this process ahead. All right, so the question is how, right? This has all been well and good. Let's get practical here. So the step 0, before you get started, I want to say you got to kind of watch your tone and body language, right? It is easy, and I've seen this done where people make jokes about it. Like, hey, come on, you're not going to kill yourself, are you? Ha ha, right? And from everything, from their tone, from their body language, even if they do kind of mean it seriously, people who are in crisis are very sensitive to this stuff. And if they feel like that you are just blowing it off and you don't care, they're not going to open up to you, right? So what you've got to do is you've got both in terms of your vocal tone and your body language has to be, even if you're a pretty jokey person, even if, I know in emergency services, we joke about death and dying and suicide and blood and gore all the time. A lot of black humor, a lot of dark humor. Right? For this particular thing, this is not that place, right? You've got to let them know that you sincerely and genuinely are worried about them, and you sincerely and genuinely care about talking to them about this, right? Because what I don't want anybody to do is take all this stuff and kind of throw out those questions in a way that makes that person feel like that they are not being taken seriously. It has to be genuine. I'm worried about you. What's going on? And that's what we have to get. Not this kind of offhanded comments, not joking, over your shoulder as you walk down the hallway. This is a sit down in a couple of minutes, or maybe more than a couple of minutes, of really, kind of serious, discussion. And every bit of you has to kind of be congruent with that. And so to start this off, we start off by asking a question. And I always say this: empathize, normalize, then transition, right? And I'll explain. When I do this, whether this is, frankly, I've done this kind of casually, but I'll also do this professionally, I'll say, you haven't been yourself lately, or if I know you're going through something rough at home. Is everything okay? Some version of that question of are you okay? Is everything okay? I've noticed you seem off your game. Everybody's got their own particular language for that. But then if that person opens up to you and says, yeah, things are kind of rough. It's been a rough couple of weeks, man. I'm really struggling with my kids. Empathize with them. So what you want to do is, by that, I mean, say like, wow, that really is rough, right? Because what you need to do is get that person to understand that you see their side of things, that it's understandable. So that's what that normalizing means. It's understandable. Hey man, if that was happening to me, I'd be pretty stressed too. Or maybe like, I know when I went through my divorce, it was really rough. I struggled, So you want them to feel like you're on the same page as them. They understand you. They're not weird for being distressed, right? Because we still have that kind of culture in first responders, right? That, yeah, I totally get you, right? And so that's what the empathize and normalize. So you ask some opening question of hey, are you okay? Is everything all right? You good? You don't seem like you've been yourself lately. That's that kind of opening question. And then what you want to do is transition into the more serious questions about the suicide assessment, right? So what you want to say is you want to transition to go, this is how I will typically do it. Sometimes when people get like that, when people have a rough time, they think about hurting themselves. Is that you? Or killing yourself, or they think about suicide. Right? This is the hardest question in the book. right? This is the one that stops everybody. They'll say, hey, man, you okay? But they won't ask this first question. You have to use the words hurting yourself, killing yourself, suicide. Got to. Can't get around it. You can't use metaphors. Have you ever thought about not being around? Because the person's gonna be like, what? Like take a vacation, retire? Yeah, I'm all over that. What do you got? Right? You have to use the words. Ask yourself, but you've made it easier because you've led into it with that empathy and that normalizing. Man, yeah, I would be really stressed too. Sometimes when people get really distressed, they think about hurting themselves. Is that you? Have you thought about this? Some version of that. You don't have to use these exact words, right? That's the one that gives people a lot of problems, but it makes sense. The second one is, you don't have to, again, ask exactly this way, but what you want to do is say something like, especially if they say, yeah, I'm really, I have had thoughts about this. But if they say, no, things are bad, but they're not to that point. You might want to ask them, has it ever gotten that bad for you? Because again, once a person's ever made an attempt in the past, we know they're at a lifetime higher risk of a second attempt, right? So these are what I call the 2 key questions. These are the things that you really have to know. Right? Is the person so bad that they thought about killing himself, hurting himself? And have they ever gotten this bad in the past? Right? Those are what I call the 2 key questions. Right? If they say no to both of those, that is a suicide assessment. You have done your job. Now, when I do this, often people are saying, maybe someone's typing this, what about the person that is actively suicidal, who denies it to your face and then goes on and has a suicide attempt? Those people absolutely do exist. But they are thankfully the overwhelming minority of cases. Right? Most people, even up until the point of their suicide attempt, are ambivalent about it. They don't necessarily want to die. They just want the pain to go away. Right? And so often once you've opened that door, if that person trusts you enough, if you've been, you've let them know that you care about them, you're worried about them, you ask them those questions and they open up to you, they will open up, right? And they'll say, yeah, I have thought about it, right? So what we know from research is that overwhelmingly, if a person answers no to those 2 questions, they are not suicidal, right? And you might be done. And I will say the overwhelming number of times you ask your friends, family, coworker, whatever, whoever, these kinds of questions, they'll go, no, never. What are you kidding me? Or no, I thought about it, but I could never do it, right? Or they will say no. If a person says no, I've thought of it, but I'd never do it, I'd move on to the next step. But mostly people are going to go, no, it's never that bad. What are you kidding me? You're done.
Drew, I'm sorry. Another question, just very pertinent, I think, to the question about asking is, whether there are restrictions on the questions that we ask as human resource pros due to the Americans with Disability Act and or other state labor laws. So basically, I think the question was, is there anything from a professional perspective that might get in our way or that people need to be concerned about asking the question from more of a legal perspective? And the other thing, just to mention real quickly, is some questions had popped up about wanting to address language in terms of use of the term successful suicide and how that actually can help to further the potential for stigma and shameful language around that. So just wanted to toss those 2 out.
Yeah, two things. The first one, the legal stuff, I will make the disclaimer, blank disclaimer. I'm not an attorney. I'm not a lawyer of any way, shape or form. It is my understanding, right, from a mental health professional point of view, that, and for most of us being mandated reporters, some of us are familiar with that world, that active suicidality is an exception to all of those. And that, frankly, I'm really framing this as you're talking to a friend about their distress and their crisis. You are not coming to this, hi, I'm the chief asking you this. It's like, I'm your friend asking you this. I'm your colleague asking you this. And that, immediate suicidality, for instance, New York has incredibly strong laws against patient-client confidentiality or patient-provider confidentiality, right? Some of the strongest in the nation. So active suicidality, imminent risk of death is, I can break that confidentiality. So most of our, these frameworks understand that in times of crisis, if a person, that there's some flexibility there, talk to HR folks about this, talk to your attorneys about this, but I think that I'm framing this, and I've come from this as a point of view. You're one human being asking another human being this, not necessarily in the context of your job title. So there's that. But check to verify this. Do not just take my word for it. The other one is talking about successful suicide, completed suicide, the language. I know I'm not completely consistent with my language. I do know that there are some very strong recommendations about that. They differ. Some people feel that it's overkill. Some people feel it's underkill. So I do know that, I did use the term sort of successful suicide. Completed suicide is probably a better term. Suicidality, I don't want to either glorify or stigmatize suicidality. So if I have used language that is not, completely ideal, that is on me for doing that. I do think that there's been a lot of back and forth in the literature and about the language to use and what to use. And I think we're still it's still a little bit of a moving target. So thank you whoever said that. I do appreciate that. I did kind of catch myself as I was saying that I used that language. I kind of tried to kind of work through that. We can maybe have a discussion at the end of this if whoever said that, and maybe some other people want to talk a little bit about that language, because I do think that's important. Again, thank you for that. And if I said something that was used in not optimal language, because I'm pretty sure I did, I apologize for that. So in that case, an overwhelming number of times, you're going to say this, the other person's going to say no. But if they do say yes, I want you to think about a little bit deeper question. And frankly, what we've just gone through is essentially at the level of some of these gatekeeper trainings, right? They train people to just ask the question, that question: Are you actively suicidal right now? Have you thought about hurting or killing yourself? That's the question that QPR and other things do. They stop. I want you guys to think about going a little further. And here's what I mean. I want you to ask a few more questions. First of all, talk about intent, talk about plan, right? Have you thought about if you've thought about it, have you thought about how you might do it, right? You are not going to put the idea in their head. I want to sort of say that right now. There's been a bunch of research on this. Asking about suicide, asking about plan does not make a person think of a plan or think about suicide. They've already been thinking about it, already have a plan. Especially if that person has already talked to you about some of this stuff, they're going to be more likely to open up and say, yeah, I've thought about X, right? This is what I've thought about doing. Because again, what we're going to do is we'll use this in our intervention step to think about how we can keep this person safe. So that's important. But also start thinking about protective factors, right? And why haven't they? Well, what's stopping them from committing suicide? Again, you're not doing this as a challenge, like, hey, how haven't you done it yet? You're saying, well, what's keeping you alive? What's keeping you around? This, by the way, is a type of intervention, right? What you're doing is kind of activating in that person's brain the reasons that they want to stick around, the reasons they don't want to die. And we do know that this can be helpful because sometimes people in kind of the depth, those protective factors start to dwindle a little bit and start to become less significant. And sort of reminding a person when you're talking about them of some of those protective factors, not, come on, you've got so much to live for, not that is not particularly helpful. But if a person says, like, I could never do this to their kids, just asking them those questions will kind of refresh that in their memory. And also it's important for us to know and for you to know when we're thinking about intervention of bringing those protective factors into play. All right. But also the last one I want to just touch on is, again, a little bit controversial in the suicide literature, but asking a person like, have you been drinking a lot? Are you coping with alcohol? Now, again, emergency services, first responders, we're well known in our subcultures for alcohol use, right? For better or worse. But you're looking at, is this person going home and drinking a lot on their own, or are they finding that that's making them more impulsive? You just want to check on them, saying, maybe we need to cut down or cut back completely on alcohol for right now. And those are your questions, right? Now, as we'll see, that's 5 questions. Is this a thorough and complete suicide assessment? Is this what I would do as a psychologist? No, I wouldn't. I would go into a lot more depth in some of these things, but it is surprisingly good. Like I said, there's been some research on these 5 simple questions, right, being a really good way to hit at the key components of suicidality, right? So 1 and 2 are those key risk factors of active suicidal ideation, right? That's that QPR, that question, right? I like to throw a history of attempt in there because, again, that's a strong risk factor for a future attempt if they get to that level again. And then just getting at those factors that are going to be more in terms of helpful in that persuade and refer, that intervention piece. What is their plan? What is keeping them from acting on that plan? And are they engaging in a lot of alcohol use as part of it? So those simple questions, right, are a not completely comprehensive, but really surprisingly thorough suicidal assessment that you can do over the course of just a few minutes with somebody. That's kind of a natural conversation. Right? Once you break through that unnatural asking the question in the first place. All right? So when I talk about this, people talk about, well, what do I worry about? Where's a single cutoff? Right? When do I say this person needs intervention? There is no single cutoff. It's a sliding, kind of graduating scale. The more the person is far down that line, the more we worry, right? The more access to means, the more lethal those means, the more we worry, right? So I just want to give you an example of how this looks, how I would think about this, and I want you to think about this. So, I've got a person here, you've got Bob, who was your colleague. Bob's 27. He just broke up with his longtime girlfriend, and you've noticed that Bob is not himself lately. He's been more withdrawn, kind of staring off into space, doesn't joke as much, and just seems really off, right? Seems down. And he's kind of broken up, so you kind of understand the reason. So, you decide to step forward and become active and ask Bob those questions. So Bob says to you, yeah, I have thought about it. I've woken up some days and said, I just want to die. It's hurt so much. I miss her so much. He asked the next question. He's never felt like this before. It's never been this bad before. This is the worst I've ever felt about this. Maybe this is his first, serious girlfriend and first long-term relationship. It just hurts so much. He also reports no plan. When you ask if you thought about how you might do it, Bob says, no, I just want to die. I just feel so horrible. Kind of vague things like that. Bob also happens to be Catholic. And you say, what do you do it? He says, well, first of all, it's a sin. I would go to hell for all eternity. I don't want to do that. And also, I don't want to hurt my parents. I know this would tear them apart if their son committed suicide. So I would never do that. This is Bob number 2, different version of Bob, right? So same thing. Bob wants to be dead, also has no history. But when you talk to Bob about, have you thought about how you might do it? Bob said, yeah, I'd overdose. And Bob has access to pills, either because maybe Bob's a medic and has access to drugs where he could overdose, or maybe knows a family member that has them or something like that. But he has an actual plan and has the ability to get to those pills. And also, instead of saying like he doesn't want to hurt his parents, he says, I suck as a son. I'm a terrible person. I obviously can't keep a relationship. My family would be better off without me. Okay? That kind of language. So let's look at both this, so that we're comparing, Bob 1 and Bob 2, or Bob on the left, Bob on the right. So let's think about risk factors, right? So Bob on the left, I want to be dead. That is suicidal ideation. That is a risk factor, right? That is something we want to pay attention to. But, he's got no history, no plan. He's got strong protective factors in place, both in terms of religious beliefs and not wanting to hurt others. So I would be concerned about Bob here on the left. I would do some level of intervention with Bob. But look at Bob on the right. Wants to be dead, also no history, but Bob has a plan. Bob has a concrete plan and has access to those means. Not the most lethal means in the world, right? But, depending on the pill and depending on the dosage, pretty close, right? We're talking about minutes, maybe an hour or two, as opposed to instantly, right? So that's a real high risk. But also, not only does Bob on the right, not have protective thoughts about suicide, he actually has pro-suicide thoughts, right? The world would be better off without me. I'm all alone in the world. Nobody loves me. All those kinds of things are kind of these pro-suicide that makes a person even more likely. So they have anti-protective factors, if you will. And so Bob on the right would have a much stronger intervention plan and a much stronger, Bob on the right might be, look, we really need to do something about this right this second, right? So I wanted to point out again, I worry about both of them, but the one on the right, clearly more risk factors, more immediate intervention plan. Right? So that brings us to talking about intervention plans. So again, you do not have to be a mental health professional to do what I'm about to talk about. This is helping you to help the mental health professionals and help your agency and help you as an individual do these kinds of things. Right? So what interventions have we got? Right? So first of all, I just want to say that we've got interventions. Right? There are really truly effective treatments for suicidality, right? Regardless of the cause. So no matter what the crisis is, we do have interventions that can help people become less suicidal and stop that suicidal crisis. We have effective treatments for mental health conditions, right? Whether it be pharmacotherapy and medications or therapy, psychotherapy, we have really good and effective treatments for depression. We have good and effective treatments for anxiety, for PTSD, for all of these, right? We do have things that can work to make this suicidality minimize and go away. The problem is they need time to work. Right? As a psychologist, I expect to see, some improvement in my patients who are suicidal or who are depressed or anxious within a matter of, let's say 2 to 4 weeks. We should start to see some improvements. Psychotropic medications take 2 to 4 weeks to kind of kick in, but really, 2, 3, 4, 5 months. We're talking about a course of therapy minimum, right? They need time. There is no intervention that we know of that can make a person suddenly snap out of suicidality, just in a matter of minutes, right? They need time to work. So what our job is outside of the mental health realm is developing interventions and thinking about ways to help keep that person as safe in the meantime, right? We are buying time for the psychological intervention to work. And so when QPR talks about referral, they're really talking about referring to that mental health professional, EAP, psychologist, therapist, social worker, whatever, right? They can start that intervention. But again, it may take a few days, a week or two to get in to see that person. It's going to take a week or two for those therapies to start, minimum, for those therapies to start taking effect, right? What are we going to do in the meantime, that 2 to 4 weeks where that person is still, could potentially still be at risk, but they have not yet gotten into, or not yet gotten a sufficient dose of whatever that intervention is to make it work. So this is really falls on everybody else, family members, friends, whatever, to think about that person's safety. And so this is where I want you guys to think about this, right? So let's talk about so this is all about safety, all about keeping the person safe. So what do I mean by that? What are some of the guidelines here? Right. First of all, any person with intent, you need to have some level of intervention. Now, the minimum intervention is setting up some sort of mental health visit, right? Now, this could be, again, everybody, we got people from all different kinds of first responder communities, all different levels of urban, rural, volunteer, professional, mixed, hybrid models. Lots of agencies have an EAP. You might have a list. If you don't have a list, I'll say you need to develop one of people where they can start to intervene. I know that a common thing I hear is, nobody understands outside of emergency services, understands emergency services. I get that. I'd rather have a person see someone who may not quite get what it means to be a cop or a firefighter, but knows how to do effective interventions than waiting around for that perfect mental health provider to show up, right? So if you are a leader in your agency, I think you need to develop a referral list. If you've got an EAP, that's a great place to start. Start asking around your community for people who do have some history and do feel comfortable talking to emergency service folks and first responders, because you want to have those handy. You don't have to go digging those up. You want to be able to go right now, here's the EAP number. I'm going to suggest everybody keep a suicide hotline number and some referrals in their EAP in their phone, right? Put those numbers in your phone. So if it's 2 o'clock in the morning, if you're out on a call and someone says, you start talking and this pops up, that you can go right now, here's a number, we can call it, right? So set those up. So even at the level of intent. Now,
Hi everyone, this is Kathy.
Drew, I don't know if you can.
Yeah, I was going to say, I think we may have lost Drew here, so if everyone can just hold on, we will connect with Dr. Anderson to see if we can get him reconnected.
Drew, can you hear us?
Okay, Dr. Anderson's going to try to log back in. So thank you for being patient with us.
We are working with Drew to see if we can't get him reconnected.
Oh, can you hear me now?
Yes.
Okay,
Yeah.
sorry, that's the weirdest thing I've ever had happen. I am well known as being a black cloud when it comes to computers, but my computer just literally shut itself down for no reason in the middle of this. So, so that was fun.
Makes it an official workshop. You might need to reshare the slides, or I don't know if Kathy, you've got control.
I'm going to reshare the slides if I can. Oh, looks like I can't share it yet. So,
Okay, Drew, I just made you presenter.
okay, so for all you guys on the call, sorry about that. You should have seen my facial expressions on my side when that happened. So we'll get caught up here. I think I can go and just start where we left off. So let's talk about keeping them safe, right? Setting up referrals, as I said, as I think the last thing I said before I shut down is that you should be able to have referrals on hand. But for people who show a little bit more than intent, right? So let's say there's more serious, I would even say at the level of ideation, we should intervene. For people who start to have, the thing we want to do is use family, friends. This is where you can come into play. This is why I included this, is that I think this is where you can really be a help, right? You want to encourage as many people as are willing to get involved to help this person get through this crisis, right? So if this means, as we'll talk about, getting in the way of setting up safety plans, call me 24 hours a day. You can talk to your husband said you can talk to him. You can talk to these other friends. Use as many people as possible to help out. All right. Now, I wanted to talk a little bit about admission to a psychiatric facility because this is something that freaks a lot of people out. The overwhelming, I know when I've talked about suicide and suicidality, something that often comes up at the end, people will either come up to me afterwards or they'll talk about it. And they'll say, well, I don't want to, if I admit this, if I know people think if they admit it, we're going to immediately like slap them in handcuffs and throw them in a psychiatric facility against their will. The short answer is that is unlikely to happen, right? Is it legal in New York and in frankly all states to hold someone against their will for a certain period of time, psychiatric admission, if they are in immediate crisis? Yes, but that is really a last resort. We can often, I routinely have patients who are suicidal who we do not have to, we have safety plans in place. We'll talk about that in a second. We do not need to admit them. It is in the back. So where we really think about admission is if a person has really serious level of they're really far down that line, right? They've got a plan in place. They're unwilling to get rid of the means. They're unwilling to give up the pills. They're unwilling to give up that. And they don't have a lot of support. They don't have anybody else. And they're unwilling to use some support, things like that. We will consider admission. But so I say consider it. And sometimes people go voluntarily. They say, I'm really in crisis. I need a few days. That happens fairly often, right? So it is something to consider. And it's the more you struggle building a safety plan, the more to think about needing a higher level of care in that way. But I included here, like I said, it is really not something we routinely do. And so I think that there's that lore out there that if you admit to being suicidal, that they immediately sort of throw you in, in the facility. That is generally not true. I'm not saying it's never happened, but I'm saying that it rarely happens. And again, the point is keeping the person safe, right? And if that's what it takes to keep a person safe, we'll do that. But most of the time, we can keep people safe with much less severe level of consequences that way, right? So what we're going to talk about now, the last thing I want to talk about is setting up a safety plan, right? And a safety plan is what we do to keep a person safe during that time, again, when we're waiting for that. So like I said, it's all about safety. It's all about keeping the person safe. Let's set up a safety plan. I'm going to walk through this. This is a standardized safety plan. This is what they're used at the VA. For some of you guys anybody who is a mental health professional will see this framework. It's what I use in my clinical practice. But I just want to walk you through the steps so you can think about where you can play a role here. So what we do is, first of all, we get people to recognize the warning signs of when they're in crisis. They may feel bad now, maybe they got some level of intent ideation, but like, hey, at night when I'm home alone and I'm not with my kids because they got taken away because, my spouse has them and we're separated and I'm really lonely, that's when I really struggle the most, right? So I put all this stuff at the bottom because it could be anything, right? It could be, I imagine myself this way. When I do this, when I go after work and go have, a few drinks, now, it used to be kind of a way that I, kind of blow off steam at the end of a shift. Now, I go home and it makes me feel worse. So what we're doing is looking for these critical moments when the person is going to struggle the most. And then what we do from here on out is we pre-plan. So again, for those of you in the fire service, we do tons of pre-planning. I, as a psychologist, do a lot of pre-planning. You should do a lot of pre-planning. So, okay, you're in crisis. Here's when you're in your worst crisis. Let's talk about what we can do to pre-plan safety. So the first step is we talk to the person and go, what do you do to distract yourself when you get upset? Right? So we want to help them come up with a list of things. And everybody has at least one or two that they don't have to depend on anybody else. I go play video games, I watch stupid movies, I read, I go take a walk. That can at least get their mind off of things, right? When people get really suicidal, they get stuck in their heads. And what we're trying to do is something that'll help drag them out of their heads. So something that will engage their attention and distract them, right? That's not an intervention, it's not a treatment, right? But it is something that's going to help buy time, right? Just keep your mind, take your mind off of things. So that's what we want to do. And just walk through that. What can you do to take your mind off stuff? That doesn't involve anybody else. Step 3 is starting to involve people and other places that can also provide distraction. So most of us have people in our lives that we're acquaintances with, maybe even friends with, but we're not that level of friends with them, right? We don't really want to open up to them about stuff, but they're funny and we can talk with them. I've had patients who say, also settings. If I go to like a coffee shop, even if I'm by myself, just being in the public kind of makes me feel better. Sitting at the firehouse and chatting with people I'm on shift with. I don't want to talk about big deep conversations, but I want to kind of engage in that sort of the banter a little bit. That takes my mind off things, makes you feel a little bit better. Right? So these are people that you don't necessarily have to have a deep conversation with, situations where you don't have to bare your soul, but you feel comfortable. And we want to pre-plan this. When you get upset, Could you go to the firehouse? Could you go to the EMS house? Could you, is there a person where maybe they're your video game playing buddy, and you can just go to their house and have a couple of hours of distraction that way. Right. Step 4 is people that we're getting kind of more and more in depth here. Step 4 is who could you ask for help? Now, almost always, if you're the person that's doing this, you're going to be one of those people, and it's frankly to the level you feel comfortable. You may not feel comfortable having them call you 24/7. That's fine. But who could you call at 3 o'clock in the morning, 3 o'clock in the afternoon? This might be, if they do have a therapist, this might be the therapist, right? But really here we're talking about lay people, right? Like just friends, family members. Could you talk to your spouse? Could you wake your spouse up? Could you wake your parents up and say, I'm really struggling? And most people can identify some people that they do trust and can open up to on that level to be able to talk to them about their being in crisis. And that person can help talk them through. People who are involved in 12-step communities often have like a sponsor. This could be helpful for that. That's part of that role. And then we go to step 5. This is where we start moving into more professional agencies, right, during a crisis. So this is where EAP numbers, suicide hotline numbers come into play. Everybody, no matter what, there's suicide hotline numbers. I'll give you some at the end of this call or this talk, have a. You can always go to the emergency room. I will acknowledge that first responders have some issues about going to an emergency room of a hospital where they transport patients to, or they would know everybody. I understand that. I also know that not always do people get the greatest mental health care in an emergency room. I also get that. I also know that both of those places can help keep a person safe. So I almost always include, look, all else fails. If there are non-first responders, I say you can always call 911. But again, some of you would be thinking, well, I am 911. I don't want my friends, colleagues, coworkers to be taking me to the hospital. And I get that, or being a part of that call. But I live in Albany County. Could I have someone drive to Ellis, right, which is the next county over? We don't typically transport there. Yeah, right. Think about those other places where you could go. And again, we're pre-planned, right? After hours contact numbers, 24-hour crisis lines. So when you're at your worst, what can you do? All else fails, like get in my car, I'll drive to Ellis, and they'll take care of me, and I'll deal with it there. Step 6, this is another place where you can be involved. This is reducing lethal means. So this is where you say, okay, you've got a plan. How can we make that plan impossible? I went to grad school at LSU in Louisiana. It's a gun culture down there. So our suicide assessment was not, do you have a gun? It's where are your guns? And we actually had a filing cabinet full of pistols that our suicidal clients would give to us while they were suicidal. We give them back when they were done, when the treatment was over. We didn't keep them forever. And that's what we did there, because it's a gun culture, right? But the point here is that we want to make it as hard, if not impossible, for people to use their favorite means. And people do have favorite means. People think, well, what if the person you take away their guns, they'll just take pills, they'll just hang themselves, they'll do something else. Well, it turns out that can be true, but it's less true. It's true less often than you think. So reducing that one way that they think that they would want to do it can go a long way. So we're putting up obstacles, right? And that's where you, as an individual, look, you may not feel comfortable holding onto that person's firearm for a while. I get that, right? But maybe someone else will. Maybe you can say, what do we do about that? And I know New York State has some issues around firearms and mental health. We can sidestep that for now. I'm just talking about keeping a person safe, right? And finding a place. Do they need to take a little bit of a break because they have access to a drug bag and that they would want to overdose, right? So think about reducing those means, becoming an obstacle, right? And revisit as needed. Right? Hey, I'll check back with you tomorrow. Let's call EAP right now. They say they can see you tomorrow afternoon. Do you want me to call you in the morning? Do you want me to hang out with you for a little while? Usually, when you're first doing this, you need to revisit more often. And as the person gets help, you can ease back on that plan a little bit. But you do need to always revisit. Let me check in and make sure you're doing okay. Right? And I say as needed because, again, that will vary over time. I just want to say this again. You are buying time. Right? We are doing everything we can, whatever it takes to keep this person safe long enough to let the other interventions start to kick in and do their job, right? That's what you as a non-professional can do, can be part of that process of buying time, right? So I'm closing up here. Some of my time for questions got eaten up a little bit with my computer glitch, but as I'm closing up, what I want to say is that, remember, frame this as what I said at the beginning. We are at increased risk for suicide, and that is not going to go away anytime soon, and some parts of it are never going to go away. Never going to go away. Some parts of an increased level of suicide risk are built into all of the first responder communities, and they're always going to be here. We have to pay attention to that. We have to acknowledge it and plan for it. But again, if we can start to develop these interventions, right? If we can bring things in from the world of mental health and these other areas, we can actually intervene successfully, help, and do what we can to minimize those people in crisis following down that suicidal progression to a completed suicide. Right? That's what we're trying to prevent. And we can do something about that, even though we're always going to be at an elevated risk, given the nature of what we do as first responders, right? So we got a couple of minutes. What I want you to do is to think about this stuff. How can you put these things in place in your agency? And again, this is particularly kind of your street level folks, right? Teach and train everyone. This is not for the leaders of the organization to do and not train anybody else. In fact, if anything, the opposite, right? So here's my goal, or my kind of goal standard here is that everybody in your agencies should feel comfortable. I don't care if they're direct patient care or not, administrators, secretaries, like whatever. People should be comfortable asking that question. I see you're in distress. Are you okay? Right? Everybody should be able to do that and feel comfortable doing that. Everybody should be comfortable finding out how risky. If that person says, yes, I am in crisis, how much of a crisis is this? How risky? Is this listen, let's get you an appointment. I'll help you find a good therapist. We'll call EAP. Or is this you're not leaving my site until we can get something in place? And this goes beyond that kind of QPR level training. I think you should be able to estimate risk. Initiating intervention. Like I said, let's call EAP. Let's talk to your spouse. Let's talk to your friends. Let's not let you out of my sight until we can make sure that your means are out of your, you're not going home and those means are there. All right. And help again with the safety plan. I don't want to make you commit to something you don't want to commit to. You don't have to be the central point in that safety plan, but you should be helpful, be able to be a help in setting that up. And if you've talked to that person and they trust you, I would at least think that you would be some part of that safety plan as, again, a person to call when they're in a crisis, right? Everyone should be comfortable doing this. If you are comfortable doing this, that's awesome. If you think that you are not, and most of the people that in your agencies are not, we got some work to do, right? Because you can help starting today, right? Again, given the numbers on this call, I know that every one of you has someone who is at some level of suicidality in your agency as we speak, right? Just given the numbers. I know that given the numbers of people on this call, there are people on this call that have a certain level of suicidality as we speak. I know that, right? This is not something I want you to think about setting up a CME for next November, right? This is something I want to put a little bit of urgency in here, right? We know these numbers are bad. We know they're not getting better. And we know that this is going to take a little bit of training. So I would like for people to start thinking about this stuff and getting more comfortable with this stuff right now. So I want to leave you a little bit with that sense of urgency. And from there, say thank you. Again, I really apologize for the computer glitch that cut about 5 minutes out of this. Questions, discussion. There is my email address. That's my the one I check every day. I've got a couple other email addresses that I'm a little less vigilant about. If you have any questions, you have any comments, you want to talk about training, you want to have me send you those references from the beginning, happy to do that. I will close with that. Again, it's a pretty short email address, just drew@albany.edu. The last thing I'll do is I'll just put up an example of some helpful numbers. So these are starting from national. That's a national suicide prevention lifeline that is available 24/7. There is a special helpline that is for fire and EMS that are staffed by people who either have a history or family members or are familiar with fire and EMS. That's another sort of crisis hotline. There is a New York State hotline. It's not open 24/7, but it's got pretty good hours. There's that number. And I'm in Albany County, so I just wanted to point out many of you have county level numbers as well. So this is the Albany County Mobile Crisis Team. They'll come out and help out, do an assessment. I know there's been a little issue with them coming out during COVID, but they exist. And Albany County also has a mental health support line. So if you guys are in different counties, check with your DOH and find out what your local, if you have a local county number. I didn't put down local numbers for local hospitals. Different hospitals will differ on how much they have in terms of psychiatric coverage, but again, we're always going to keep people safe at an emergency room. So with that said, I think I will stop sharing my presentation. We've got a few minutes, again, fewer than I would like to go with this. So
Drew, thank you.
Let's go.
Thank you so much. We do have a bunch of questions. I've been keeping track of them. And I guess the first thing I just wanted to ask is, assuming we're going to run out of time probably, would you be willing to maybe look at some of these questions offline and at your discretion, come up with some responses.
Happy to. I got nothing going on for the next little bit, so I'm happy to stay on and leave a little after this, right? So I know if some of you guys have to leave, I'm sorry again, I apologize. Feel free to send me questions. I'll also answer some of these offline.
Okay. So I'm just going to go in the order that I had them. Let's see, we talked about the stats. This was a comment. My experience is that law enforcement doesn't use employee assistance. There was some back and forth on what's the best way to try to recruit law enforcement officers to be part of Warm Lines. Just so you know, there was some back and forth in the Q&A about that. A comment on whether law enforcement agencies have thought about partnering with mental health agencies to provide strategies to process vicarious and secondary trauma. I don't know if you have any experience with that particular, partnership.
Well, yeah, I'll just say really quickly that that's a good point. We are trying to come up with, and I know more about this in the fire and EMS worlds because I'm just more familiar with them. With these kind of help buddies, help each other out. I've seen corrections has actually done some work in this as well. Trying to build some of those peer support groups, which I think can be a good resource. I actually have seen a little momentum in that way. I know historically we've been horrible about this, but where I think we are getting a little bit better. If people want to help be put in touch with some of those trainings and things, I'm happy to do that. They can email me. Gary may know some of those as well. The last one is, I do think it is helpful if you are a leader of an agency for you to try to start to find people in the community who do kind of value, maybe either have some experience, family members, whatever, in law enforcement, fire, EMS, to start finding those people to help out. Because I know that a lot of cases, particularly for career agencies, police in particular, a lot of times people see the psychologist, that's the person that gives them the stupid test that keeps them from being in the service or not. They don't see them as a particularly useful help. So I think that that's something we really got to kind of change. And so you might want to have one person that does that stuff and another person who does the more kind of like helping you process trauma one.
Excellent. Well, other questions, if folks don't mind sticking around. There's a question about, do you have any familiarity with the Columbia Protocol and any reflections on use of that? And another question about ideation. What if someone says no to ideation but states they don't have the means to do so, but previous attempt involved pills and they're prescribed psychotropic medications? So more from that safety planning perspective, how might you address that?
Yep. So the first one is I don't know that I'm familiar with the Columbia Protocol. It may just be because I know it under a different name or I'm not connecting to it. So if someone wants to send me that, I can definitely talk about it a little bit. That's a really good question. So if a person had a previous attempt, what we're really looking for there is how closely are the current circumstances mirroring those previous circumstances. So if a person says, yeah, I took pills, but I'm not at all suicidal right now, we would say, okay, low risk, but that's where I would say, if you start to notice them getting upset, you might want to go, are we getting closer to those circumstances? Are we narrowing that gap to the point where they've got active, intent again, right? Because let's face it, someone had a suicide attempt at 25, at 45, it doesn't mean they can't have pills in their house, right? It doesn't mean, it's really just, but if they do start getting upset, we know that that was their means before, we do want to start watching out for that. So I kind of raise a little flag in my head that if you do start to see them get upset, that would be where one of those kind of harm reduction things you want to first think about.
Got time for one last question that I'll put out there. And for folks who are still on the line, like I say, I have curated all of the questions and comments that have come up, so I will run those past Drew. And when we send out a recording and the slide deck afterwards, we'll try to have some condensed response as well. But in the beginning, it was discussed that suicide ideation is inherent in first responder culture. What are your thoughts about stress or ideation as a line of duty injury? And the asker further clarified, the departments don't identify stress as inherent injuries or illness. Is suicide a line of duty death? I guess, in your opinion or your way of thinking, or what do we know about that?
I mean, that's a really, really good question, right? And I'm not going to speak for everybody in the entire sort of first responder culture. But, so what we do know is that it is true, and this comes out of one of our more recent theories of suicidality, that it is inherent in our jobs, what we do, whether we're volunteer, we're paid, or whatever, that the stuff that we see, the kind of stresses we go to, do make us more vulnerable to suicide and a lifetime suicide risk. I would argue, somebody could argue, that confers that risk because it was happened on the job, that suicide should be considered a line of duty death. I know there's been a lot of controversy about that because people don't want to admit that it was a suicide death, and they don't want to have to say that in a public ceremony about a line of duty. But I think you can make the case that if a person developed that capacity because of their role as a first responder, even if that suicide death was not about a bad call, let's say, or that really bad fire, but it was just about building the capacity through that, I think you can make that case. I don't know, again, that happens at a level much higher than me. But I do think that that's an important thing to think about. And I also think it's important if we start having those discussions, it helps us acknowledge that this really is a risk factor, that we are at elevated risk. And if we pretend that, in my own area, we've had a number of suicides of first responders over the last 5 years. 0 is too many, and we've had more than that. There have been discussions about, do we call this a line of duty death? And again, like I said, I've seen kind of firsthand some of this reluctance to call it that because it didn't directly happen because of, they weren't, within 24 hours of, that fire, like we know in the fire service, right? That's the line of duty death. It didn't happen because of this. The only opening we've got is a little of that kind of 9/11 first responder stuff, even down the road. If we say they got their illness because of 9/11, that even if down the road, we'll call it a line of duty death. There's a parallel there. So we got a lot of work to do, I think, before we make that kind of the first responder norm. But I do think it would help destigmatize some of this stuff.
Excellent. Are you open to another question?
Sure. Yeah. I've got to look at my schedule. I got something in 20 minutes, so we're good to go. Okay.
So we'll take this as the last question. This is, might not be a simple one, but I think it's a good example. I'm curious as to what someone with your level of training would say to that person you come across who is standing on a bridge strongly contemplating suicide. So this is, they're right there, right?
Wow. You guys give me really the easy questions, don't you? I mean, here's what I want to think of overarching, right? The overarching goal here is to delay that act long enough to get the person safe. So I do think, starting to talk about those things like, what keeps you from doing it now? Now that person is right on the bridge. They haven't jumped yet, right? Which means they're ambivalent, right? Up until what we know from people who have not completed suicide, they had a suicide attempt, and we've been able to talk to them. They have said that up until the kind of that very last moment, they have been ambivalent about it, right? Overwhelmingly. And so even up to that last minute, if you could say, hey, what have you got? Not that kind of classic, but you have so much to live for, right? That doesn't really work. But ask them to sort of start to retrieve those memories. What are those preventative factors, right? Those protective factors. And also, frankly, I'm going to be distracting them while someone else can grab them. You know what I mean? Because it is staying safe, and that involves a physical intervention. And, if you actually have seen, there's those videos on YouTube of people doing this. It is rarely someone just talks them off the ledge and they sort of climb off on their own. It's basically someone who's talking with them, keeping them engaged, getting them to think about reasons to live long enough to let some physical intervention happen, whether that's grabbing them or, the really cool swinging the ropes down and, and knocking them backwards. But I do think that in that moment, the intervention you want to do is around thinking about those protective factors, right? Not activating the reason their plan anymore. It's those reasons that they have that they would not do it, they would not want to do it.
Thank you. And I think with that, just out of respect to everyone's time, we'll call it a day. A lot of comments, Drew, just thanking you and very appreciative of the information. People are looking forward to getting the slide deck. So for everyone on the call, thank you so much. We do not have a specific date for January or topic yet, but keep your eyes out for that. Be safe, everyone. Take care of yourselves. Happy holidays, and we look forward to seeing you the next time around. Bye, Al.
Thank you, everybody.